This last tutorial is about problems in headache classification. You might think that after 3 successive editions of the classification, with literally hundreds of experts involved, that there wouldn't be any more problems. But this is not true. Classification is very, very difficult, and we only able to improve it successively and gradually, and only able to improve it when there is sufficient new evidence to support changes. And as I mentioned in a previous tutorial, the amount of classification research conducted is rather limited. Here, this will be my kind of legacy, what I left over and could not solve as chairman of these 3 successive editions of the headache classification. The first problem is with chronic migraine. A very, very important entity, the most affected migraine patients, the most disabled migraine patients. Why is it a problem, the current set of diagnostic criteria? For 2 reasons. One reason is it does not take care of patients who have high frequency migraine but no other kind of headache. So let's say a patient has 12 migraine days a month but no other headaches. That patient does not have chronic migraine, but the person is completely disabled by such frequent migraines. The other problem is that it actually mixes up headaches with migraine characteristics and headaches with the characteristics of tension type headache, which is not very good. There's been a fairly big study suggesting that patients who have high frequency migraine, meaning 8 or more days of migraine per month, but don't get up above 14 headache days per month, that they are almost or as affected as patients who fulfill chronic migraine criteria, and therefore there's a suggestion to change the diagnostic criteria, but this will take more work and more consideration by the new committee. Migraine with brainstem aura has been much disputed. The current set of diagnostic criteria is clearly too open. It has, of course, a lot of sensitivity, but very little specificity. And there has been also studies now suggesting how these diagnostic criteria could be tightened. This is important because all experts agree that it's an extremely rare disorder. But when these criteria that we have at the moment are applied to big materials, there are quite a lot of patients who have who fulfill the diagnostic criteria for brainstem aura. Another problem is how brainstem aura relates to vestibular migraine, and this is completely uncertain. Vestibular migraine is a kind of popular entity that people have been talking about and have used as a practical diagnosis for a very long time. But the diagnostic criteria before the ICSD-3 were absolutely terrible, in my opinion, completely useless. In the appendix of ICSD-3, we presented somewhat better diagnostic criteria for vestibular migraine, but to my knowledge, these criteria have not been field tested and have not been used in scientific study. This will be something to look at for the new committee when some people have done more clinical studies using these appendix criteria for vestibular migraine. Tension type headache remains a somewhat disputed area. in epidemiological studies, 75% of the population have had tension-type headache within the last year. So it's so common that one could even discuss whether it's a disease or not. But in the more, when it occurs more frequently, it certainly is a problem for the patients. There's a strange tendency, especially among people who have worked only in tertiary headache referral centers, to deny the existence of tension-type headache. This is, of course, ridiculous because migraine does not affect 75% of the population. But to really sort out the difference between tension-type headache and migraine is a big challenge. And whether diagnostic criteria for tension-type headache should be tightened or not is still an open question. If they are tightened, there will be a lot of patients who don't fulfill these criteria and who don't have migraine, and what do we do with them? A huge issue for future research. Then we get to the group of trigeminal autonomic cephalalgias. There are the rare kinds of headache called SUNCT and SUNA. And at the moment, it starts out with explicit diagnostic criteria for SUNCT, and then it just says that SUNA does not have conjunctival injection or lacrimation. In other words, SUNA requests less than SUNCT. And so SUNCT is in fact a subform of SUNA. And why this should be so complicated remains an enigma, because these are extremely rare disorders. It would be nice to just define SUNA and maybe SUNCT as a subform of SUNA. Here I show the diagnostic criteria for new daily persistent headache. You already heard about that in a previous tutorial. But the reason I bring it up here is this problem of monothetic versus polythetic diagnostic criteria. And here you have 4 monothetic criteria. The headache has to be persistent and has to fulfill B and C. If it's not persistent, you can't have it. There has to be a distinct and clearly remembered onset, with pain becoming continuous and unremitting within 24 hours. And it has to be present for more than 3 months. But what do we do if it's not persistent from the beginning, but say after 1 week? What do we do if it's not been continuous immediately? And so it just illustrates that monothetic criteria are not necessarily good. And I think the whole classification, it would be needed in future to look at all the diagnostic criteria that are monothetic and see if there aren't cases that would not fulfill all of these monothetic criteria, but still would be very typical. And therefore, in many places in the classification, I think that monothetic criteria should be replaced by polythetic criteria requiring 1 of 2, 2 of 3, or something like that. A huge area of problems is how tension-type headache relates to cervicogenic headache and to temporomandibular disorder. At the present time, the same patient who is seen by a neurologist might get the diagnosis of tension-type headache, but if the patient goes to another doctor, for example, an orthopedic surgeon, it may be called cervicogenic headache, and if the patient goes to a dentist, it may be called headache attributed to a temporal mandibular disorder. These diagnostic criteria are overlapping, and it is because the basis of all these three pain syndromes very often is tender areas in the pericranial muscles and neck muscles. And it has never been resolved how to separate these entities. And as you probably all know, the ideal of classification is that a kind of headache can fit into one and only one place of the classification. Right now, the same headache type can fit into three different places of the classification, namely chronic tension type headache, cervicogenic headache, and headache attributed to temporal mandibular disorder. How to resolve it is not easy. I tried to do it in the third edition of the classification. We were not successful. It's a big task for the future classification committee. These are some problems. There are others in the classification. There are patients who get a chronic headache after an absolutely trivial head trauma. They walk out of the door and bang the head into the door frame, or they are bending down, and as they go up, they knock the head up in a shelf or something else. Traumas that have where there is very little force involved, and one cannot possibly imagine how such a trivial, insignificant trauma could cause any derangement in the brain or in the head. Nevertheless, patients have, since that trauma, chronic headache, which is actually completely typical of post-traumatic headache. It's not separated out in the classification. I think it should be. But what the explanation is unknown, and it requires more research. Then we have in all the chapters on chronic headache, on secondary headaches, we have the possibility that these headaches don't disappear. Let's take an example. Headache attributed to arterial dissection, for example. It's well known that arterial dissection of the carotid artery, for example, will cause an ipsilateral headache, and usually goes away, but not always. There is a study showing that in a third of the patients, the headache persists. And this is also true after stroke. This is true after many of the other secondary causes of headache. And it has been very poorly described, something where we need a lot more research to be done, and something where the new classification committee can maybe fill a gap. We have had, for all the three editions of the headache classification, a chapter called Headache Attributed to Psychiatric Disorder. It doesn't mean that we think that headaches are psychiatric as a basis. And it's been very much debated, because previously, even patients with migraine were always told that it was a kind of nervous headache and so on. And this is, of course, is completely wrong. But there is a feeling that if a person has a depression, it can also be associated with headache, and that the headache can disappear when the depression is treated. But throughout the three editions of the classification, there has been a wish for more research to show whether and to which extent headache can be attributed to a psychiatric disorder. And nothing has come out in the literature. So it's a big issue. Should that chapter be completely removed from the classification, or should one leave it there in the hope that people will eventually start to study whether psychiatric disorders can induce headache? And the last line in this slide mentions trigeminal neuralgia. It's still uncertain whether these diagnostic criteria are too exclusive, because they are monothetic in many cases, and this is a new set of diagnostic criteria that were made up by committee work on the basis of opinion of experts, but they really need to be field tested. Those are the only small items I have with regard to problem areas. As you can see, there will be a lot to do for the new headache classification committee once it starts working, and I wish my successors all possible luck in their important but difficult task. Thank you very much.